Okay, welcome everybody to another episode of the Serdentity podcast. I am your host, Elizabeth Dewar Anthony, and my guest today is the lovely Tosha Kozloski, who is an internationally known speaker about all things dental hygiene. And I want to talk to her today about some of the stuff that she talks about because I think it's really important. If we're going to stop traumatizing people in the dental chair, we have to start doing things differently. And Tasha's all about that. So, hi.
Hi,
You are so cute. I can't even stand
you're too sweet.
it. so,
Doing a great
so you and I, can you believe that was like 2022 that we
Was
talked?
it really?
Yes. I thought, oh, it had to be
It
like
does
last year.
not feel like that long ago since
I
we
know.
got to do this.
I know. So you and I talked, and you were telling me all about your this the chair side microscopy, and focusing on letting people know that it's not about clean versus dirty. I really want to get rid of that language around the hygiene appointment because it's not a cleaning and they're not dirty. This is an infectious process, and it's a disease based in bacteria, and these bacteria are there, and we're feeding them so well with our mouth breathing and our high sugar diet. It's not even people with good oral hygiene still can have a lot of bacteria in the mouth. So that's one thing I want to talk about. And I'm also excited to hear from you about ozone, which I know has a lot of great benefits in oral therapy. So give my three listeners the the rundown on this chair side microscopy that you do and that you talk about.
Yeah, so I love a microscope. I did not always have a microscope when I was practicing in my earlier days, and I've always been extremely passionate about treating periodontal disease. I started my career working for a periodontist because I was like, oh my gosh, in school I thought, why would I want to work for a GP practice doing healthy prophies all day long? Like that's going to be boring.
There's no healthy prophies, but anyway, go ahead.
Naive Tasha.
Right.
And so I simultaneously worked in a GP practice and for a periodontist and was like, whoa, everybody bleeds. What's going on? And my
Yes.
technology for treating that infection was no different at the GP practice versus the perio office. It was
Right.
just that I may have been doing SRP in preparation for flap surgeries and things like that. And so I really just felt like there had to be a better way. And through the right education, the right mentorship, and, probably a lot of luck along the way, I stumbled upon all of this amazing technology and opportunities that we've really have had some of it at our fingertips for longer than we realize. It's just that, sometimes things don't catch steam simply because we've got a lot to do in our hygiene operatories.
Mm-hmm.
When I first was introduced to the microscope, I was kind of thinking like, I don't need that. I already use salivary diagnostics. I have great verbal skills. Like my patients know they have disease. But I was convinced with a lot of nudging, like, hey, this can really change your life.
Who was nudging you?
The doctor that I worked for.
Nice.
Yes. And his dad had a microscope in his practice in the 80s. And
What in the
Dr. Paul
80s?
Kais in the 80s.
Wow.
So Dr. Paul Kais introduced all of this in the 80s. And Dr. Paul Kais really is the founder and the godfather of microscopy. So like he was
Yes.
the first to prove that the morphology, what we see, higher volume, higher motility, certain shapes of bacteria are just not part of our good bugs. So like nobody should have spirochetes in their mouth. They're never a good bug. Now,
Right. Yeah,
cockroaches are
gross.
good bugs. It's like, and in hygiene school, we learn about microbiology, and then we forget all that, and then we
Right.
jump into
I
like
learned for a
hygiene-related
test. Yeah.
studies. And then it's like the great divide between the the gram negative and positives and all the different things. It was like, I forgot all about that when I got into hygiene
Mm-hmm.
school. Then when I started looking at the microscope, it was like, oh my gosh, it took the conversation about periodontal disease from, 10 to 13 minutes to like 2. I mean, the process of taking a slide takes, you do your probe chart. If you see a change in the patient's mouth, you just simply say like, hey, Elizabeth, I'm seeing some changes in your gums today. You have
Mm-hmm.
inflammation, redness, and even bleeding. So no more pocket depths, no more bleeding points, no more dental terminology that we learned in school. Just we talk infection
Yes.
like a
Yes.
physician. Then we simply say, I think you maybe came in contact with some bad bugs and your mouth got sick. So we look at the microscope. That whole process takes maybe a minute. You get it into
Mm-hmm.
focus. It's super, super quick. And then they see all these creepy crawlers on there. And then
Mm-hmm.
from there, they go, oh my gosh, that's in my mouth. And you're like, wow, this definitely explains the changes I was seeing in your gums today, Elizabeth. You came in
Mm-hmm.
contact with some bad bugs and your mouth got sick. So the conversation completely changes from,
Yes.
you didn't do a good enough job brushing, or the patients
Mm-hmm.
that like have been a patient of the practice for a decade or more, they
Mm-hmm.
come every 6 months, they do everything that you ask them to do, but they're just bleeding every single time.
Mm-hmm.
They don't have a spicule of calculus. They don't have any debris on their
Mm-hmm.
teeth. They do an amazing job, but you touch their gums and it's like waterworks of blood.
Mm-hmm.
Those are the same patients. It's like you can think of these bacteria like termites in the foundation of a house. They live deep inside the gum tissue, not just on top of it. And so when we can show our patients the creepy crawlers, they get it. So that
Mm-hmm.
opens the door to this whole oral systemic conversation.
Yes.
So it's like what I would always share with my patients is when your gum tissue gets swollen, it gets leaky and permeable. So leaky gut, leaky gums. It's the same thing. So all
Mm-hmm.
those little bugs that are swimming in your mouth,
Yes.
they're going to be swimming in the rest of your body too. And so
Yeah.
then the patient goes, oh, so then if you
Right.
happen to notice that your patient has psoriasis, let's say,
Mm-hmm.
or another inflammatory condition, an autoimmune disease, well, that patient's immune system is already attacking itself. So what do the doctors do? Put it on an immunosuppressant drug. So,
Right.
so that their immune system stops attacking itself. Well, now they're even more likely to get a gum infection because if they come in contact with bad bugs, their immune system's already going like, hey, red flag here. Like I'm already on fire. And
Mm-hmm.
they're just so much more prone to getting an infection. And it's harder to get them healthy a lot of times too. So showing versus telling, I mean, we do it in restorative dentistry all the time.
Mm-hmm.
Now we take a PA, we think that we see a radio, a lesion at the apice, let's say of number 3. If we've got a cone beam, you take a cone beam. And then how big is that lesion on the cone beam? It's like,
Right.
ugh.
Right.
Yeah, it's crazy big. And so the same is true. We see a fractured tooth, we take a picture and show the patient. It's super easy to visualize like, oh my gosh, I have bad bugs. What do I want? I don't want to have bad bugs. How are you going to get me there, Elizabeth?
That is awesome. And that's exactly what I mean when I say a different approach. And you know, and you already said it, you aren't flossing your teeth. And there's none of that. So and these bugs, man, they're bad. And they and then you can start discussing with patients, the oral systemic connection. And I'm hoping that our profession starts to go more toward, so sort of systemic first and then oral, you
Yep.
know, that the mouth is attached to the rest of the body. And, it's the start of your digestive tract. And
Yep.
if we have to keep the whole thing healthy. And I love that you mentioned autoimmune dysfunction. We have all this inflammation going on, your poor immune system, I always explain it like it doesn't know how to act. Okay, it's all overwhelmed, it doesn't know what to do, so it's attacking the wrong stuff,
Yep.
or it's not attacking what it's supposed to, and it's attacking your own whatever lymphocytes, or in my case, my thyroid hormone. I had Graves' disease, so my thyroid's cranking out all this hormone, but my immune system is destroying the T4 as fast as my body can make it. And I'm like, I don't feel good.
Yeah.
It's the same, that's
Regulation. It's not just in one spot. I mean, systemic affects everything. And we don't always see it. I found, until I really started like looking at the microscope, I found some of those oral systemic conversations to be difficult to start because I
mm-hmm,
was kind of like, okay, so you have diabetes and that can affect your overall oral health. And so you can be up to 3 times more likely to have bone loss because of it. And then the patient would just look at me like, huh?
what,
Versus,
right,
wow, you have a lot of inflammation, you have bleeding. these bad bugs are causing a great amount of inflammation. That's telling me that your immune system is not able to control these bad bugs. It potentially could be because of your diabetes. Do you know what your A1C is? When's the last time you had that checked with your doctor? Have you had a fasting glucose lately? And then the patient starts to go, oh, you know what? My number's been a little high lately. And then that opens the door to, oh, maybe that's why I'm seeing these changes in your gums today. And then they go, oh, wow, my whole body's connected. So the oral systemic conversations for me just were easier when I could look at their medical history and go, oh, I can talk about it like this. Oh my gosh, you have family history of heart disease. Well, I don't have any periodontal pathogens in there because they make you more likely. So I'm going to make sure that we keep you on a short leash. And the airway stuff too. It's like patients that have obstructive sleep apnea and our kids that aren't breathing right, that are mouth breathers, and then their gums look terrible. And we go like, oh my gosh, what's going on? It's like, well, extreme dysbiosis, and the child can't breathe. And every time they go to sleep at night, the cortisol is crazy because their body sees that as a stressful event every time they go to bed.
Yes. And, modern life is stressful chemically. Um, you know, we're all walking around, the vast majority of us, unless you're like a Tibetan monk or something, constantly in this fight or flight. So you have a woman in fight or flight gets pregnant, and her entire pregnancy, that fetus is getting bathed in her cortisol. And then, so the fetus is growing under stress. The baby is born. And because of the maternal stress, they're behind the 8 ball from the get-go. And because of bottle feeding, mouth breathing, and the soft diet, they can't grow a skull, a jaws, big enough for healthy, functional breathing. So it's like, laddle, 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 laddle.
100%. And it's not very well understood. And I don't know about you, but in school, I wasn't taught anything about breathing.
Oh my God, girl, I was in school when you were a baby.
It's still been a couple decades for me, but I don't know if they're even teaching a lot of it now, like how to look for a child that maybe has sleep issues, or, talking to your patients about, does your 5 or 6 year old still do bedwetting? Do they have ADHD? Could you fit a dime in between every single tooth?
Right.
No child anymore.
Nobody. When I was in school, oh my God, it was about the teeth and gums and tartar.
Oh, yes.
And I've said this in other podcasts. If you killed the patient, that was okay, as long as you got all the tartar off. There was hardly any discussion of how you treated this patient as a human being. They were a class 1, class 2, class 3, class 4, and how like, you don't get graded on, are you nice to them, or are you compassionate, do you have empathy? None of that was like part of the when that I remember.
No, I totally agree with that. And I think too, because of the laser focus on calculus, part of that is, we want to pass our clinical boards, right? Because we want to get our shiny new license. But when we get so focused on the calculus, a lot of times we're not so focused on talking about the infection with our patient. And so unfortunately, a lot of our patients are left feeling like they had a heavy-handed hygienist, because we got so focused on cleaning the calculus off that the patient didn't know, oh, it wasn't my heavy-handed hygienist. It's because my gums are swollen and it hurts when she touches them. It's like, okay, so the inside of all of those pockets, I don't care if it's a 2 or a 10, they're ulcerated. So when you barely touch it with your instrument, you're like giving it a million or billion paper cuts all the way around. It hurts. And unfortunately, a lot of our patients won't tell us. They just grit and bear it. And they go, I hope I never see that hygienist again.
Right. Then they go out to the front desk and complain. Now, one thing I do have to say was over time, I was able to develop a scaling technique, a hand scaling technique, where I was able to kind of sneak under the tissue. I would always start in the back and go to the front, and I would move the instrument back and forth. They talk about the roll and a working stroke versus an exploratory stroke. So you go along, you find a deposit, you bear down, and you remove it. Of course, you have to have sharp instruments that were, made preferably within the last 100 years. Um, but what I saw a lot, what I see a lot is hygienists. They bear down on the instrument before they have to, and there's a lot of excess manipulation of inflamed tissues, and and it's painful.
Mhm.
And pain and shame do not make for a
If we
good.
identified the infection earlier and understood it earlier before it was that bad, it's easier to treat, to clean, to
Mhm,
remove the stuff.
mhm.
And, a lot of times too, I'm like, just get out some of that Cetacane topical, which is one of my favorites.
Yes, my favorite. Yep.
Compounding pharmacies. I mean, I personally, there's a couple other topicals that I'll leave nameless, but they're not as
Right.
good.
No,
And so
they don't.
there's
Cetacane is
compounding
the best.
pharmacies that make super killer stuff too. That's just like, I'm not talking the gel, but put it in a little like Luralox syringe, rub it around
Mhm.
there. Oh my gosh, gets it again under the gum. It's like using etch tip, works slick.
The Cetacane hospital gel. Uh,
I've used the hospital gel. This is like Cetacane liquid.
right. The liquid, I mean, I like the liquid too, but I one time got a sample tube of Cetacane hospital gel, and it was the bomb because it's a gel and it stayed. I mean, I
Yeah.
even got like a little bit of tissue blanching.
Ah, very nice.
But
Okay,
this
I have
was,
not used that.
well, they probably don't even make it anymore. I mean,
Oh, I'm sure they do.
I keep forgetting how old I am. But and sometimes for consistency, I would mix a little bit of just regular benzocaine topical with the Cetacane just for consistency so that it would stay a little bit better. But yeah, and I don't understand why more hygienists don't make use of that. Well, actually, I do understand, because I remember being a new hygienist and having my head up my butt and having a patient ask me for the topical. I'm like, let's not go. Like,
Well, I think too, so many of us think that we know what it's going to look like after we probe.
right.
Guilty of this, like going around, everything looks great. I'm going to get you shined up, Elizabeth. And then I get in there, I'm like, oh my God. And
Right.
by then I'm 30 minutes in. So I'm like, okay, I guess we're just working on floss technique today. And so it's like, what am I supposed to do? And then it's like the 4 millimeter pocket that's been a 4 millimeter bleeding pocket for 4 years. It's stable. It's a stable pocket. I didn't learn to do anything different. Like that wasn't in my wheelhouse. And so a lot of those same patients are the ones that have that constant bleeding, that it doesn't feel super good. We don't feel like we need topical because it's not that bad. But really what they actually need is therapy. Antimicrobials, and disorganizing the biofilm, not
Yes.
just signing them up and sending them on their way.
Right. And breath instruction and dietary counseling.
Yeah.
When you roughen up the person's diet, that helps to make the mouth just a little bit more self-maintaining, because you increase their salivary flow. And when you get a person to have a consistent lip seal where their mouth is there, again, that's going to improve the whole the system and make it a little bit better. But it's hard for us modern humans to keep our mouths closed because we're talking. You can't be a nose breather if you're talking.
Yeah. 100%.
So, we do what we do. We do what we can do. So walk me through how you use that microscope chair side. Like, how does it work?
So depending on the practice, so some practices, if every hygienist had a microscope, then you could very easily use it on every single patient. But most practices don't have a microscope in every single operatory, even if they do. And so in that situation, you're typically sharing with your colleagues. And so 2 to maybe 3 hygienists can share a microscope. And so in a situation like that, I'll use, since that's the more common one, is we would just, during your chart prep that we're all doing, we all should be doing anyway, we would just identify the patients the next day. So if I was doing my chart prep, I always like to do it at least a day or two in advance. I would identify the patients that needed a slide the next day. So that could be any patient that had bleeding on probing, bleeding on scaling, any positive standard signs and symptoms of inflammation. And so I want to determine, well, is that just inflammation or is that infection? Primarily, when we see inflammation in somebody's mouth, it's infection. It's not.
Yeah.
And we can typically tell the difference between like, okay, that person actually did eat popcorn last night and that's what caused the inflammation, or oh, it was the floss cuts in preparation for today. That's the inflammation, but they probably still have
Oh,
infection.
come on. That's so like, those are
And so
old wives' tales.
that's, I know it. So essentially, is what I would just identify. I'm going to take at least 2 slides per day minimum. So I would identify those 2 patients so that I'm prepared. So then before I even go get my patient from the waiting room, I have everything ready. It takes 15 seconds maybe to set it out. And then as soon as I do my full mouth probe, so I do all my appointment sequence the exact same up to my full mouth probe. After I probe, I would just determine like where the deepest pocket was, take a plaque sample from there. Again, it takes like 5 seconds. I've already probed, so I know where the inflammation is. I just take some biofilm or plaque attached to the tube. That's where we want the attached stuff because has the higher pathogen load. From there, I just put it on the slide and then I say, okay, Elizabeth, let's take a look at your plaque sample. Now, if I saw positive signs and symptoms in your mouth, I would simply share that with you. Like, and if I said the same thing last time, I would just say that. I'm like, you know what, Elizabeth, last time I did find inflammation in your mouth, and I know you've been working really hard on your home care. We talked about diet. We talked about XYZ, whatever it was. Let's take a look at everything today. You know what, today I'm really finding the same, things. And so I know you've been working hard on your home care. So let's just take a look at the microscope, see if you maybe came in contact with some bad bugs and your immune system just probably isn't taking care of them. So then we look at the microscope, we see all these creepy crawly bacteria. Patient goes, oh my gosh, like I was saying earlier. And then from there, I always just share with the patient, think of the cleanings we've been doing like a routine car wash. What you now need is the full detail, really spending time getting in the nooks and crannies, places we just can't reach with the traditional cleaning. We're going to use some medicine. I'm going to show you some home care techniques, and I'm going to have you come back a couple times so that we can really treat this infection in your mouth today. And so I'm changing that entire conversation. I'm not going over, oh my gosh, you have 5 and 6 millimeter pockets. Or if you were a patient of the practice for 10 years and maybe you've had 5 and 6 millimeter pockets for 10 years, I don't even go over that. You know what? This infection has actually started to necrose the bone that's holding your teeth in. So we really need to arrest this infection. And then from there, we talk about it from an infection standpoint. Okay, the next step is to take a lab test. So we know based on the microscope that certain shapes are not part of your good bacteria, but we don't know what they are without a lab test. So the lab test is just going to tell us what bad bugs you came in contact with. There, I take my lab test. And then after that, what I'm wanting to do is get the patient scheduled, get the financials gone over, and get them rescheduled to come back for therapy. Now, I'm not doing a prophy that day. That was probably scheduled. But if you're doing a lab test from a financial standpoint, it's a wash because you're going to compensate that money difference with the lab. Then you'd go over your therapy with the patient. And that's when you can, again, revisit their medical history with them. Talk about why your immune system isn't fighting off these bacteria, because chances are we're all coming in contact with bad bugs all the time, but we're not all getting sick. And so why are some people getting sick? And that's where this whole immune system inflammatory response comes into play, because it's all about the host's immune response.
Yes.
React. So if you and I came in contact with the same bugs, our immune systems may not react the exact same way. If I have strep throat, I happen to come down with COVID, then I come in contact with some bad bugs, probably it's a 5-alarm fire. But I'm like ticking and good. I'm like eating right. I'm working out. I'm getting my vitamin D outside. I'm going for walks. I'm getting my sleep. And I come in contact with bad bugs. If I've got a rip-roaring immune system, it's probably fine. My good bacteria takes care of it. When we start seeing changes, signs and symptoms of positive infection, that's when those bad bugs are not taken care of. And so then I get back, and the main objective that I have with therapy is, yes, I'm going to get the calculus out of there, but I'm going to more be focused on disrupting and disorganizing the biofilm. Because if you don't penetrate the biofilm wall, it don't matter.
Mm.
Patient at home. So brushing and flossing is not enough for a lot of patients because that mushroom cloud is a protective layer. So it's like if my tooth, if my arm is the tooth surface, the biofilm
Mhm.
is like this. It's got those finger-like projections. So
Wow.
then the saliva and all the nutrients in our spit is just feeding it, but the bad bugs are inside. So if I'm
Oh,
brushing,
wow.
flossing, and I floss, the biofilm fell off. Well, now maybe it just attaches to a different tooth. So if
Mm-hmm.
I haven't used my ultrasonic to create that tornado-like effect to implode essentially the bacteria or disorganize it, or use
Mm-hmm.
something to oxidize that biofilm wall,
Mm-hmm.
really done anything for the infection. So if I'm just like scaling away and cleaning all the calculus off, I'm not doing anything to the infection. I'm just sweeping it and smearing it around. So then
Oh my
I need to
God.
make sure that my patient disrupts and disorganizes the biofilm every single day. So my patients go home with some type of water pick, oral irrigator, perio
Mhm.
protect trays, something, because we can have the best technology in our practice, all
Mhm.
of the tools, the lasers, the guided
Yeah,
biofilm, the ozone, all the amazing things that we have
right,
now. But if our patient doesn't know what they're supposed to be doing at home, or we
right.
didn't know to show them,
Mhm.
our success will be limited because the bacteria isn't just in our gums. In direct proportion, however much is in your mouth, is pumping through your blood.
Right.
60,000 miles of blood vessels. And so my
Mhm.
focus with those patients is make sure they know what they need to do at home. And then with the microscope, it's like, remember those creepy crawlers that we saw in your mouth? This is what you need to do at home to get rid of them. This is a team effort.
Mhm.
My job to get them healthy. It's our job.
Mhm. Now,
The
when you do the lab work, so that gives like an analysis of which bacteria are present in the
That's right.
mouth, and that's a good touch point to, this P. gingivalis is indicated in, different like Alzheimer's and heart disease. So you can, um, you know, that's more useful information to make that oral systemic connection.
It is. And also, we want to do another test at roughly 3 months so that was my therapy successful? Did,
Mm-hmm.
did our teamwork accomplish reducing that pathogen load enough to where then the patient's immune system can take back over? So we have our baseline of our initial
Mm-hmm.
test, and then we do our therapy, we get them back for follow-up, we keep giving them a high five when they're doing the right thing. So it's like with the
Mm-hmm.
water pick, if my patient comes back and they're looking awesome at their 6-week follow-up, I'm like, okay, Elizabeth, don't stop what you're doing. It's looking
Mm-hmm.
so good. What you're doing is working. Keep up the great work. Don't stop because
Right, don't stop now.
keep going. And if it doesn't look good, okay, so we haven't quite gotten there. So what more are you willing to do at home for me? And
Have
so
you?
then afterwards, we take another test and go
Yep.
compare.
I'm sorry I interrupted you. Have you heard of Primal Health LLC?
Yes, they're new on my radar. Yeah.
Okay, Emily Stein is the microbiologist who founded that company and created.
Oh, yes. I was thinking of another one. Yes, I know Emily.
She
Yes, we've met
is,
in person multiple times.
oh my
Yes.
God,
I'm sorry.
she is so freaking smart.
She is.
So Fossident is like a prebiotic, right?
Yep.
So we should be handing this out like candy to our patients to, to help. Besides the physical removal, we
Yeah,
need.
it interrupts the bond cycle, like the exact combination. We'll have
Yeah,
to have Emily tell you. But
yeah.
yes, Dr. Stein's amazing.
And she made, now I guess she's come out with the same stuff in like a perio protect tray.
Okay, I didn't know about the tray. I only knew about the
Yeah,
lozenge.
I just heard about it recently, and so that's pretty exciting.
She also has some like tablets that you can put in your water.
Yes, put them in the water. For people who, like, people in nursing homes, right? That,
How this all started was
yeah,
with her grandmother in
yeah, her
nursing.
grandmother.
Her story is so cool.
When I met her in person last October, oh my God, it was, yeah, last October. I did nursing home dental hygiene for 13 years.
Oh,
So
I
she
didn't
and
know
I
that.
kind of bonded over that. But yeah, I spoke to her like last week, and we had a great conversation. But I just wanted to see if you had heard about that product. And I was going to say, if you haven't, you need to I think it's something that's really beneficial.
Yes, for sure.
And but ozonated water too.
Love it.
Let's talk about the ozone.
Yes. So ozone water, which is not the same as using the gas for like ozone insufflation, and it's not the same as ozone oil.
Right.
So they have a little bit different processes. And ozone has really been used in biological dentistry for a long time.
Yeah.
So this is like mostly new to us in the GP world. And so the cool thing about it now is that you used to have to make ozone every day in the practice. It would take about 20 minutes and you would get like not even like a whole bottle like this.
Right,
and
right.
It was very time consuming. And so you kind of had to be selective. The thing with ozone too is it breaks down really fast. So it's considered like nature's antimicrobial. So we now have electrolytic ozone through BioSure. So Darren Simmons is the owner of BioSure USA. He's amazing. He's an engineer. He's just great. So now what we have is like, I even have a spray bottle in my room. So like this is like an ozone spray bottle, and it's 3 ppm. But then they have the units that you can use in your office that have 10 ppm. So what the machine does is it's just oxygen with an extra oxygen on there. So it's O3. So what the electrolytic does is it basically shoves them together. So we've got two of the oxygen and we got an extra guy. And so they like to be in pairs though. So this little guy over here is like, where's my dance partner? I need somebody. Well, the awesome thing about that is it goes searching immediately. It's going, okay, where's my dance partner? It likes the microbes. So it goes for the viruses, the bacteria, the fungi. So when we use it either to spray our rooms to clean them or use it in a patient's mouth, it's attacking the bad guys. So I like to say it kills the bad guys and supercharges the good guys. Plus it also supercharges your mitochondria. It has a slight a coagulation as well. So it can help with that a little bit, the bleeding when we're using it in people's mouths. So I love it just to use through your water lines. So it's amazing because for water line cleaning, most of our water line cleaning products within the office only work on the water that's flowing through. It gets any bad bugs out of the floating in the water.
Right.
But we don't really think about what's attached to the inside of that hose.
Yeah,
so.
You don't want to know.
Right. And so what ozone does.
Chinese food, don't ask.
What it does though is over time, it breaks down all that biofilm that's on the wall. It's great. However, you will notice as that stuff that was already in your line starts to break down, you may smell a little funky smell. You may see little specks of black stuff coming out of your water lines and things like that, just temporarily until that ozone has cleaned out all of your tubing. So it can kind of be a little bit of dentistry's dirty secrets, kind of, how so many of us allow our patients to close over the suction without the backflow preventers on there.
Right.
And so I love it just because it's not going to hurt the patient if they swallow it. I mean, some people are like, oh my God, what if my patient swallows that ozone water? Well, what ozone doesn't like is heat and acid. What's in your stomach?
Right. And acid.
And so the tricky thing about it is the half-life is fast. So as soon as you make it, your working time, it's breaking down constantly and it's just going to turn back to water. So worst case scenario is it just doesn't have that extra oomph. So what I share with my teams that have the electrolytics or that they're making it is just before your SRPs, before your therapy visits, before your perio maintenance, just go refill your bottle quick. Some fresh so that your patient can really get the benefits of that ozone.
So the ozone water is in your handpiece in your Cavitron.
Yeah. So if you're just hooking up like your bottle for your machine,
air water syringe. Beautiful.
And like if you were using like guided biofilm therapy or anything like that, you can just stick the ozone water in that. So that would be your water that you use.
I think
actually, I don't know for sure if that's approved in EMS's unit. I do know people do it, but I don't know that it's like within your warranty. So listeners,
right.
I know that Woodpecker doesn't care.
So the BioSure, I met him too. I was at this Bob Barkley Study Club in
Oh, he is great.
oh my God. Well, I was all nervous because it's all these heavy hitters, and I'm like, oh my God, I'm nobody. But
Not true.
it was a great conference, and it was actually so it was great education. But the first night, there was a after dinner there was a like a cocktail party, and there was this guy playing guitar, and of course I had to get up and sing with him, and we freaking killed it. We were so great together, and
I
so
love
it
it.
was like one of the best nights of
Right there.
my life. So that was awesome.
I love it.
Um, so but ozone, but you can also, can you have ozone at home? You can have ozonated drinking water at home.
So you can. So like I have a unit actually in my house from Darren that that has two options. It has hydrogen water, which is so anti-inflammatory. There's like over 300,000 studies on hydrogen water over the age of 30 for the anti-inflammatory effects and all that kind of stuff. So mine, I have a button where I can push H2 or O3. So my O3 out of the tap is 4 ppm. So if you have at least 1 ppm, you're active to kill even C. diff. So the one thing I love
Wow.
about, like, within the operatories of of our dental offices is what we don't usually do is read the directions of our cavi wipes.
Yeah.
And we don't realize like, okay, like it needs to be wet for a minute and a half at least. So like a super wet wipe it all down, let it air dry. Don't start setting up right away. It literally has to do that. And it still cannot kill C. diff ever. However, a spray bottle at 3% can.
So
And it kills within seconds. So it's way faster too.
why doesn't every nursing home have ozonated water?
And you can do that, and they have the purifiers for the air, and it kills MRSA too.
Wow. Or hospitals.
Yeah.
Why don't hospitals and nursing homes have that?
I think some of them do, and it's definitely catching on more, and it's definitely been catching on a lot more in like the food industry. So if you've ever had food at a Cheesecake Factory, Subway, the things like that, all their produce, that's how it's cleaned. If you've ever drunk out of a bottled water, if you bought bottled water from the store, like it used ozone to clean the water, and then they seal it, and so that you can't get, there's no bacteria that can get inside of it. So it should be. And probably part of it, I suspect, is that electrolytic is still pretty new on the scene. And so it's easy to do electrolytic now, to like force those molecules together. However, the old fashioned way, which is still totally doable, and a lot of practices still do it, it takes 20 minutes to get a little bit. So it's not, when you think about that, even within a dental office, it takes that long. Like, how much extra time do any of us have?
No,
I mean, half the
time
time,
is
like,
money.
I
Yeah.
get to lunch and I'm like, I had to pee all day.
Yeah.
Like we're just busy. We're just busy. So yeah, I hope that it will be more widespread, especially as more people learn about it, because it's still new in dentistry.
Well, I have to say, I'm proud of our profession and people like yourself who are trying to move this whole thing forward. And the more we talk about it, right, the more we talk about ozone, the more we talk about these bacteria, and the more you're out there educating hygienists on how to do this in real life, and it's doable in real life. It's not, it's something that is perfectly doable and achievable by the average hygienist. Of course, the average hygienist has to get her boss to, or his or her boss. Now there's a lot of guys now.
Yeah, now there are others, which is great.
Right? I'm like, dude, what are you doing here?
I love it. There was some male hygienists that they're like, we're guy hygienists. And I'm like, oh, I like that.
I like that, guy hygienist. It's great. So, wow, we've been talking for almost an hour, and
time flies when you're having fun, Elizabeth.
Well, you know what? You are awesome.
No, you are awesome.
I knew I wanted to have you on here today because, just like I said, you and I, well, we're forward thinkers, and
share a lot of DNA.
Yeah, that's right. And just to get the word out there that it is possible to practice, efficient oral systemically centered, non-traumatic
Yes,
dentistry. And it's the way to the future.
it really is. It really is.
So I want to thank you so much for
My
agreeing to meet with me today.
Anytime.
And after I've worked my way through all these people I want to bother, then I'll probably be back. I'll be calling you in another 3 months or so. Well, I've already talked.
I love it. No, I love it. I love it. It takes all of us really banding together to do this. And I think for our industry too, when it comes to continuing education, especially, it was never stressed to me that I needed to keep up with the science of
Right.
what's changed. And in the, 2 decades that I've been a dental hygienist, there's been huge changes. Like I didn't know about the ecological plaque theory or any of these things that came out that have continued to evolve. And so when continuing education has been presented, especially at a lot of our state meetings, there's not a huge emphasis on the changes and the new understanding of periodontal disease. And now like the understanding of not only verbal skills and scripts, but how to do non-traumatic dentistry and how to practice different ways and the ways we can communicate. I mean, airway is so big and there's just not time in the curriculum. And so I think too, just getting the word out about there are classes, there are people that can do this. If you've never been exposed to it, you don't know what you don't know.
Well, airway's gonna have to become part of education, because whether you think so or not, you are practicing in the airway, and patients trying to breathe creates a lot of these negative reaction spirals that make for bad Google reviews, lawsuits, and so airway, whether you think it does or not, it really does affect our job day in and day out. So we're going to have to start, getting there.
I mean, we're putting our patients in a submissive position,
Right.
just to clean their teeth. So they're already, if we think about dogs, when they lay on their back, it's like,
right. That's how you're vulnerable. So,
yeah. And so it's even more traumatic if you're not only in a vulnerable position, but you can't breathe.
Right. You can't breathe, and
you're trying to be a compliant patient.
Right. And never, and yeah, you're trying to be compliant, but then, you have the patients who come in defensive, right? They're ready for a fight because they know that this is what's going to happen. Yep. And what happens is, I need to take some x-rays, and the patient says, I don't want them. And then
it's like, oh.
Yeah. And then it's like, well, legally I have to, blah, blah, blah. And the patients, so then you're in a power struggle, like right off the bat.
Yeah.
So, my message, which goes along with your message, is there is a better way.
Yeah.
And I'm all about it.
Completely agree.
All right. So
I could talk to you all day, Elizabeth. Love it.
I could talk to you too. So I'm going to get you back here on my podcast.
I love it.
All right. Talk to you soon.
Talk to you soon.
Bye, hun.
Bye, hun.